Join me, Mike Colbert, as I host the 9th Annual PIPE Conference, October 23 and 24 in Edmonton. PIPE is Alberta's largest primary care CV event. We have a fantastic lineup of presenters from Tina Kronick and Mike Allen, James McCormick, Tony Nikinchuk, Vinay Prasad, and Victor Montori. They're going to cover a wide variety of topics, including diabetic medications. So many choices, so few options. Dementia update, pediatric rashes, medical cannabinoids, and the perennial favorite, new, true, and poo. PIPE does not receive any industry support, and all speakers are conflict of interest free. So sign up for your individual or clinic rates for an outstanding, almost exclusively virtual, fantastic CV event from the comfort of your home or office. For more information, please see www.pipeconference.ca. Hope to see you in October.
C'est officiel, le FMF 2020 sera virtuel. Du 4 au 7 novembre, participez au plus grand congrès de médecine de famille au Canada. Le FMF offrira plus d'une centaine de séances et ateliers de formation de grande qualité fondés sur les données probantes avec un horaire flexible. Le contenu restera affiché en ligne pendant 30 jours. Cette année, nous vous réservons d'incroyables plénières. Dr Carole Herbert parlera de la nécessité de trouver de nouvelles façons d'intégrer les données probantes dans la pratique, malgré le rythme effréné du monde d'aujourd'hui. Le conférencier professionnel Stéphane Megan s'attaquera à des sujets difficiles pour inspirer en nous la résilience et l'excellence au moment où nous en avons le plus de besoin. Dr Yona He donnera ses réflexions sur l'année 2020 qu'elle voit comme le moment de prendre des risques dans la pratique. Durant les 4 jours de l'événement, vous aurez l'occasion d'explorer un hall d'exposition virtuel pour vous informer sur les innovations et les outils en médecine de famille. Et ce n'est pas tout. Vous pourrez échanger avec vos pairs dans notre espace de réseautage en ligne et discuter avec eux des questions importantes. Les tarifs pour participer au FMF seront beaucoup réduits cette année. Vous pourrez vous inscrire dès maintenant au fmf.cfpc.ca. Suivez-nous sur Facebook, Twitter et Instagram.
It's official. FMF 2020 is going virtual. Join us for Canada's largest family medicine conference, November 4th to the 7th. FMF will offer more than 100 top-quality, evidence-based sessions and workshops on a flexible schedule. And they'll be available online for 30 days. This year, we're including some incredible keynote speakers such as Dr. Herbert, who will examine how we have to find new ways to incorporate evidence into practice in our fast-paced world. Professional speaker Stephen Megan will tackle tough issues and inspire resiliency and greatness when we need it most. Dr. Yona He, who will share her thoughts on how 2020 is a year of practicing dangerously. Throughout the 4-day event, you'll also be able to explore the virtual exhibit hall to learn about innovations and tools in family medicine. Don't forget to connect with your peers in our online networking space to discuss important topics. FMF is being offered at greatly reduced rates this year, and registration is now open at fmf.cfpc.ca. Connect with us on Facebook, Twitter, and Instagram.
Good afternoon, and welcome to Practical Talks for Family Docs, the College of Family Physicians of Canada's live clinical webinar series. My name is Alan Grill, and I'm a family physician in Markham, Ontario, and a part-time physician advisor in the Department of Programs and Practice Support at the CFPC. I'm joined in the studio today by Dr. Anna Wilkinson, who is a family physician and works as a GP oncologist. She's the program director for the PGY3 Family Practice Oncology program through the University of Ottawa, and is chair of the Cancer Care Member Interest Group at the CFPC. Today's topic is demystifying breast cancer, and it's great to have Anna with us to enhance our knowledge in this area. More information on the Member Interest Group section, or MIGS, at the CFPC can be found on our website under Member Services, and a link will be posted in the live chat. I also want to give a quick plug for some of Anna's and her MIGS work regarding the Oncology Brief Series, which is coming out in Canadian Family Physician in November of 2020. This is an evidence-based review for family docs of various oncology topics, and please have a look out for that. In terms of land acknowledgement, we acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The CFPC recognizes that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The CFPC respects that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all attendees to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. Just a few housekeeping issues before we get going. Our audience today is joining our live webinar from either Facebook or YouTube. In both platforms, you can send questions about the webinar, and we will address them at the end of the webinar in our live Q&A session for the last 15 minutes. If you're using YouTube or watching on YouTube, please submit your questions in the chat window. You will need to be logged into your own Google or YouTube account to do so. If you can't see the chat window, you may be in full screen mode. If you're using or watching Facebook, you must be logged into your Facebook account to submit questions in the chat window. In terms of Mainpro credits for this event, if you're watching this as a live webcast, it is eligible for 1 Mainpro Plus credit. In order to claim your credit, you will need to complete a short registration form and survey at the end. The link will be posted in the chat or comments window at the end of the webinar, and we ask you to complete that by the end of the day, Friday of this week. And with that, I want to introduce both my friend and colleague, Dr. Anna Wilkinson, to take us through demystifying breast cancer.
Thank you, Alan. So today we're going to be talking about all things breast cancer. My name's Anna Wilkinson. My conflicts of interest, I don't have any relationships with any industry, but I have received honoraria for speaking, and I have received funds to travel to make meetings for the CFPC. So our formal learning objectives today are to describe screening guidelines and diagnostic workup for breast cancer. We're going to list and talk about potential adjuvant therapies for breast cancer and talk about survivorship care for breast cancer patients. But in a more general sense, what I really want to do today is take you through breast cancer all the way from screening to survivorship care. And my overarching objective is to build some bridges between oncology and family practice to help mind the gap or bridge the gap between these two disciplines. So I work as a family physician, but also as a GP oncologist. And so I have a foot in each of these worlds. So what I'm planning to do today is distill down a very complex topic and try and make it relevant for family physicians so that you are more able to support your patients when they're going through breast cancer. So let's start with screening. Screening is certainly the wheelhouse of family physicians. It's what we know and do. I'm going to review the Canadian Task Force on Preventative Health Care Mammography Guidelines, or breast screening guidelines. These were updated in 2018, and you've probably seen them published in the CMAJ. So in a nutshell, these guidelines say for women age 40 to 49 that there's no screening recommended for breast cancer. And the task force used a number needed to screen to express the benefit of screening. So the number of women that you need to screen with a mammogram to prevent one death in this age group would be 1,724 people. I like the infographic that they have on their website. This really allows you to visualize this, and it's a really helpful tool to use with patients. So what their infographic says is that for every 1,000 women that you screen, 294 will have a false positive result. Those are the women in blue. Of those 1,000 people that you screen, there'll be 7 diagnoses of breast cancer. 3 of those diagnoses will be overdiagnosed, so those are the red women, and less than 1 death will be prevented, and that's the green there. For women aged 50 to 74, recommendations are mammography every 2 to 3 years. And you'll see that the number needed to screen goes down as age goes up. And this is really a reflection of the increased incidence of breast cancer in these age groups. The guidelines also are very clear that you need to have a discussion with women about the value and the preferences that they place on benefits and harms from screening. The breast cancer, or the guidelines, also suggest that there's no role for any further imaging. The guidelines recommend against clinical breast exam, and this is a recommendation for which there is no evidence. They also recommend against breast self-exam, and again, this is based on low certainty evidence. So I will say, when you look at guidelines, they are just that. They're guidelines. There are nuances, there are gray zones, but I think that guidelines are only as good as the evidence that they're based on. And so what is the evidence that these guidelines are based on? If you look and dig deep into the text, they'll tell you that the studies that they used to look at the benefit, mortality benefit, were done between 1963 and 1991. And so I think we have to think long and hard about this, because to inform our screening practices in 2020 based on a trial in 1963, a lot has changed since then. There have been changes in diagnosis. You can see this mammogram here, the film version in 1980 versus the digital version in 1995. There's been surgical improvements. There's been treatment improvements. And I think we know that if you diagnose breast cancers earlier, that the morbidity of treatment tends to be less. The task force quoted, based on these RCTs that they looked at between 1963 and 91, a mortality benefit of anywhere between 15 and 21%, depending on your age group. But if you look at some of the studies that weren't included in these guidelines because they weren't RCTs, so for example, the Pan-Canadian study, which was published in 2014, this is an observational study, but it looked at 2.7 million women in Canadian provincial screening programs, and it found a mortality benefit of 40% for screening with mammogram. So if you think back to that diagram and the number needed to screen, if that mortality number is different, if the overdiagnosis number is different, all of a sudden the number needed to screen looks quite different. I'd like to just touch on overdiagnosis. Family physicians are very comfortable with overdiagnosis and the concept of this in prostate cancer. We think nothing about an elderly gentleman in his 80s with a prostate cancer that we don't want to identify because we think it wouldn't cause a problem in the rest of his life. But I feel that overdiagnosis in a 40-year-old woman with breast cancer is a very different issue. And I think we have to work very carefully to determine what exactly that overdiagnosis rate is. And the issue with determining the rate of overdiagnosis is that it takes a very long follow-up period to determine which cancers are going to become a problem and which cancers aren't. So current estimates of overdiagnosis vary anywhere from 0 to 57%, which calls into question really the validity of these numbers because it is such a wide range. The Canadian Task Force in their recommendations stated that overdiagnosis rate was 50%, but there's been lots of evidence, including the Malmo trial you can see below, where they followed women after a screening study for 15 years after the end of the study and found that overdiagnosis rate was more like 10%. So again, I think it's important to know the data behind the guidelines, so when you're having that discussion with women about values and preferences, you can have an informed discussion. One last question I think as family docs we get asked about by our patients and we need to think about is when to start screening. So 1 in 5 breast cancers is diagnosed in women in their 40s, and we know that 1/3 of lives lost to breast cancer happen to women in their 40s. So this is a disease that causes significant impact in this age group, and yet we're not screening. I like this graph because it really shows that breast cancer doesn't just start when you hit age 50. So these lines show the incidence, cumulative incidence of breast cancer as age goes on. So clearly, if you set your bar at the blue solid line and start screening at age 50 versus at the blue dotted line and start screening at age 40, there's certainly some breast cancers you're going to miss. Breast density is a fairly new concept that's becoming more and more prevalent in the media, certainly, and in patients' awareness. Just recently, it's been mandated in the States that all mammogram reports include breast density information. Most provinces in Canada currently also report breast density information. So what is breast density? Breast density is graded. It's the ACR, so the American College of Radiologists, and it's rated from A to D. So A are breasts that are almost entirely fatty tissue, C are dense breasts, and D are extremely dense breasts. So why do we care about breast density? The reason is twofold. So number one, the more dense the breast, the higher the risk of developing breast cancer. And number two, the very fact that those breasts are dense means that the cancers that you might find in a mammogram are obscured. We can't really diagnose them as well. So these women are certainly at higher risk of developing breast cancer and at higher risk of developing what we call interval breast cancer. So breast cancers between screening examinations. So what do you do when you get your mammogram report back now and it says ACR C or D? So you need to communicate this with your patient. You can consider doing yearly mammograms to decrease interval cancers. And you can look at your patient's risk of developing breast cancer. And my favorite way to do this is use the IBIS tool. It's online. The link is here. This is a tool that takes into account not only a woman's family history and personal characteristics, but also breast density. And so it will give you a lifetime risk of developing breast cancer. And then you might want to consider for intermediate risk women supplemental ultrasound, or if they're high risk based on this, refer them to a high risk screening program. But there are no formal sort of guidelines on breast density at this point from the task force. So moving from screening into diagnosis now. Many breast cancers will be identified on screening mammography, but some will be diagnosed by patients coming into your office with clinical findings. And you and I and everybody who works in family practice has certainly had women come in with new lumps that they felt in their breasts. But not all breast cancers present as lumps. Some breast cancers present just as a nipple discharge without any mass associated with it. There may just be skin changes with thickening or nodularity. Some breast cancers are occult, meaning there's no primary in the breast, but there will be axillary adenopathy. And up to 6% of women that present with breast pain will actually ultimately be diagnosed with breast cancer. So how do you work up a woman who comes in with findings? You need clearly further imaging. Mammogram is usually the first step, but it's important to know that for mammograms, you can order screening mammograms, which have 2 views for each breast, or diagnostic mammograms, which have additional views and magnification. So for workup of a clinical finding, you should be ordering a diagnostic mammogram. This is usually paired with ultrasound, which is really good in younger women and when the findings are cystic. MRI is reserved for very rare cases where you have changes that don't show up on mammography. So things like if it's skin changes only and these aren't seen on mammogram, or if there's nipple discharge and no findings on mammogram. When you get your mammogram back, either screening or diagnostic, it's going to be reported according to the BI-RAD system. So this is a uniform quality assurance tool that helps kind of make sure that all the recommendations are the same. So BI-RADS 1 and BI-RADS 2 findings are negative or benign. And in these cases, you should just resume routine screening. BI-RADS 3 means probably benign, but you need to follow these people more closely. And for women with BI-RADS 3 findings, they should be having a diagnostic mammogram at 6 months and every 6 months for 1 to 2 years. BI-RADS 4 and BI-RADS 5 are when you're getting into suspicious findings, and this is when you need a biopsy. Biopsy can be done in a number of ways. Fine needle aspiration is perhaps the most known, but the problem with fine needle aspiration these days is it doesn't give very much tissue. And so it's really inadequate most times for the pathology that you need for breast cancer. So better biopsy techniques would be a core biopsy. You can see on the bottom there, you get a bigger piece of tissue, or excisional biopsy, where there's wire localization of the tumor and then it's removed in the OR. Finally, if the changes are really just in the skin or nipple, you can consider a punch biopsy. I will say there's cases where you can be fooled, so you need to be aware that breast cancer can be inflammatory breast cancer. And in these cases, it's really an aggressive form of breast cancer that's within the lymphatics of the breast tissue. And you'll see really only erythema and swelling in the breast. Paget's disease, on the other hand, presents with, it almost looks like an eczema of the nipple, so that the cells are really in the areola or nipple. And again, you won't see anything on mammogram with this. You need to do a biopsy. I would just say my clinical pearl in the area of diagnosis is really, if the woman in front of you has a finding that you're not comfortable with and her biopsy or her imaging results come back non-congruent with what you're seeing, you have to consider that there might be a sampling error or perhaps a false negative on the imaging. So you really need to think about whether you re-biopsy this woman, whether you re-image her, or whether you just follow her along with close follow-up clinically. Because we've all heard of stories where people have negative mammograms and then a year later they have breast cancer. So just really watch and be aware that there is the possibility for sampling error. When you diagnose someone with breast cancer and you sit with them in your office, usually one of the first questions they're going to ask you is, what's my treatment going to look like? Women have heard all kinds of stories about breast cancer treatment, and they've heard horror stories. They hear the negatives as opposed to the positives often. And so I think to be a family doctor and support patients through their treatment journey, you need to understand a little bit about what the treatment's going to look like. To really understand breast cancer treatment, we have to understand the breast cancer biology a little bit. So these are the things that you would see on a pathology report. And I'll walk you through them because it's really important that you understand all these factors, because this is what's going to ultimately dictate treatment. So cell type, most common cell type of breast cancer is ductal. Lobular is rare, and there are rarer types, but generally we're talking about ductal carcinomas here. The grade of breast cancer, as family physicians, we're very used to Gleason scores and grades in prostate cancer, but we're not as used to it in breast cancer. So this is a measure of the differentiation of the cells and ultimately the aggressivity of the disease. And breast cancer grade is rated from grade 1 through to grade 3. So grade 1 is well differentiated, grade 3 is poorly differentiated and more aggressive. ER/PR status is talking about estrogen receptor and progesterone receptor status. And so if these are positive, this is a cancer that is hormone sensitive and you can use endocrine therapy. HER2 status, so HER2 stands for human epidermal growth factor receptor 2. And so the HER2 protein or receptor it's a transmembrane tyrosine kinase receptor. It goes through the membrane, and when it is bound extracellularly, it kicks off a cascade within the cell that leads to cell replication and cell division. And in women who have HER2 overamplification or are HER2 positive, they'll have many of these receptors so that you can get uncontrolled cell growth. This is important because with trastuzumab or Herceptin, you can bind these HER2 receptors outside of the cell and prevent them from causing cell growth and replication. The other thing that you have to understand breast cancer treatment is staging. Staging, as you know, reflects tumor size, reflects nodal status, and the presence of metastases. So stage 0 breast cancer is LCIS and DCIS, so lobular carcinoma in situ or ductal carcinoma in situ. Stage 1 and 2 breast cancers are smaller tumors, so up to about 5 centimeters with a maximum of 3 nodes present. And these are the lower risk operable tumors that usually you would have adjuvant or therapy after surgery. Stage 3 tumors, by this point, you're getting into higher risk tumors. They're bigger than 5 centimeters usually, or more than 4 nodes. And these are not operable initially. They will need chemotherapy or treatment to shrink them down preoperatively. Stage 4 breast cancer is metastatic cancer. So you will see mets either in the lungs, the liver, the bones, the brains. These are common sites of metastases from breast cancer. And interestingly, median survival for metastatic breast cancer is now about 3 years, often up to 5 years. So women can live quite a number of years with this. So this is a little graphic that I created to try and bring home the complexity and the number of different drugs or treatments involved in the treatment of breast cancer. So each color in this schema represents a different kind of treatment. Not all women get every single one of these treatments. It really depends on the characteristics of that breast cancer. So going back to the biology or the pathology, are they HER2 positive? Are they ER/PR positive? So I really just want you to take 2 things out of this slide. Number 1, that there are many different kinds of treatments that women may receive for their breast cancer. And number 2, that the treatment for breast cancer can go on for a really long time. The timeline we're looking at is from surgery on up to 10 years of treatment. So let's walk through. I'm going to walk you through each one of these arrows. You'll see them in the top corner there. We're going to start with surgery, and I'll explain sort of generally who gets what and why for each of these treatments. So for surgery, you'll probably notice that some of the women you diagnose with breast cancer get a lumpectomy and some people get a mastectomy. So who gets what and why? It's been shown that lumpectomy with radiation therapy after it is equivalent to mastectomy. Lumpectomy is clearly more desirable, cosmetically, morbidity, all these reasons. It's a much smaller surgery. And so it's done preferentially if tumors are small enough that they can be removed entirely, if you can achieve negative margins, and if women can get radiation post. Mastectomy is done if those situations don't exist, or sometimes if there's an underlying genetic mutation like a BRCA1 that would warrant mastectomy. One of the things you need for breast cancer staging is nodal status. And there's 2 ways to find out whether there is cancer in the lymph nodes in the axilla. One of these is sentinel node, and the other is axillary dissection. Axillary dissection has a lot more morbidity than sentinel node. We've all seen women with really significant lymphedema, with shoulder pain, with limited range of motion in their shoulders post-dissection. And so really it's clearly much more desirable to be able to do a sentinel node biopsy. With a sentinel node biopsy, a tracer is injected in and around the tumor, and you look at where that tracer goes to. Which node does it go to map out the lymphatic drainage from that tumor? That node is removed and looked at intraoperatively, and if there is cancer within the node, then you proceed to an axillary dissection. So women who have no nodes clinically would be candidates for sentinel node biopsy, and women who have clinically positive nodes would not get a sentinel node biopsy. They'd go right to axillary dissection. So who gets chemotherapy? This is a really complex question, There's so many factors that go into this: the benefit of treatment, the comorbidities of the patient's preference, the risk of the tumor. So what I'm giving you here are some general sort of rules of thumb, but clearly it's much more complex for this. But at least you get the sense here of who probably wouldn't get chemotherapy. So people who don't need chemotherapy are those with small tumors, so less than 0.5 centimeters, and no nodal involvement. People with women with slightly bigger tumors who still have no node involvement, but have favorable prognostic factors, can also sometimes get away without chemotherapy. And those prognostic factors, again, are going back to that biology that we talked about. They'd be HER2 negative, ER/PR positive, and low grade. And finally, genomic profile is used more and more to determine a recurrence risk. And so women who are low and intermediate risk in genomic profile would not get chemotherapy. I think one of the key points to take from this is this shows you truly the benefit of screening with mammography, because if you can catch these tumors when they're really small, you're going to save a woman from having to go through chemotherapy. And that's a really significant thing to do. Women who do get chemotherapy are usually those with positive lymph nodes. They would have tumors that are larger with no node involvement, but this time if their prognostic factors are unfavorable. So if they're HER2 positive, if they're ER/PR negative, so not hormone sensitive, or their disease is high grade, or women with high risk genomic profiling. Genomic profiling is one of the most exciting things to have happened in the last few years in oncology and breast cancer oncology. And essentially what this is a 21 gene assay that breast tumor tissue is sent away for. It's the most common one used in Ontario anyway, is called Oncotype DX. And this assay gives you a recurrence score. And there was a recent clinical trial called the TAILOR-X study, which showed that for women with low and intermediate risk breast cancer, there was really no benefit for chemotherapy. And so all of a sudden, it's become okay not to treat people with chemotherapy, whereas we might have before. When you dig down into this trial and try and understand what is going on, it seems that a lot of the benefit that we'd been ascribing to chemotherapy was actually coming from endocrine therapy all along. And so really, the endocrine therapy is really the crux of treatment for women who are ER/PR positive. You may remember back to that staging slide when we talked about stage 3, the higher risk people. And these people are not usually eligible for surgery up front. They need it to have it after chemotherapy. And so neoadjuvant chemotherapy is when you take that surgery and you put it after the chemotherapy. So this is done in the case when you have really large tumors, so greater than 5 centimeters, or very high risk disease, so lots of nodes present, or more increasingly, women with triple negative disease. So that's HER2 negative, ER negative, PR negative. The benefit of doing neoadjuvant chemotherapy is that tumors that you might not have been able to resect become operable, that you have time to do some genetic testing while these women are on chemotherapy. And if they're found to have an underlying genetic mutation, you might change your surgical approach. You can facilitate breast conservation. And most importantly, often, is you get a lot of information out of the response of the tumor to chemotherapy. And this helps with prognosis. So common chemotherapy regimes that are used for women who are going to be getting chemotherapy are below. So AC plus T, fectocitaxel, TC. Chemotherapy usually starts about 8 to 12 weeks from surgery because you need time to heal from your surgery. The choice of which of these chemo regimes that you'll use depends a lot on the patient and their comorbidities and the toxicities. You don't need to know the regimes, but I think there's a couple of things that are important here. So one, that chemotherapy is given in cycles. So it's given every 2 to 3 weeks usually. And so if you look at the number of cycles here, generally women will be on chemotherapy from anywhere from 4 to 6 months. Additionally, the names in red there, adriamycin, epirubicin, these drugs are anthracyclines, and anthracyclines can cause really significant cardiotoxicity. This is important to know about as a family doctor because often the cardiotoxicity doesn't present until many, many years post-treatment, often more than 20 years post-treatment. And women will show up in your office, they will have had breast cancer treatment many years ago, but they'll present with dyspnea and new leg swelling. They'll present with CHF. And so as a family physician, you have to kind of register that they've had treatment and they've had an anthracycline before to know that they're at risk for cardiotoxicity from this. So you need to have a low threshold for the investigation of dyspnea in patients who've had these drugs. And if they do have cardiotoxicity, it's not something that's reversible, but you would manage it as you would manage anyone else with CHF. If you're not sure if they've had anthracyclines or not, you can ask patients if they've had the red devil. You can see epirubicin here, it's bright red. Most patients will remember this, absolutely. So we've moved through surgery, chemotherapy, and now we're going to talk about trastuzumab, or Herceptin is the other name. So much as I went through earlier on when we talked about the biology of breast cancer, this is a monoclonal antibody that binds to this HER2 receptor and prevents it from causing cell replication or division. It's only given to women who are HER2 positive, and it's every 3 weeks for a whole year. It's not given with anthracycline chemotherapy because one of the biggest side effects of trastuzumab is that it causes a decrease in your ejection fraction. And that is cumulative with the anthracycline, so they're given separately. Trastuzumab really changed the landscape in breast cancer treatment for patients who are HER2 positive. The addition of trastuzumab caused a 48% reduction in the risk of recurrence and an almost 40% reduced risk of death for these patients. So it's really made a big change. Radiation therapy comes next. You may remember when we talked about lumpectomy, that lumpectomy is only felt to be equivalent to mastectomy if it's followed by radiation. So if you've had a lumpectomy, you would have whole breast radiation. So you'd have 50 gray, and that would be broken down into 25 individual fractions. So a fraction a day. So about 5 weeks of radiation. This can also be hypofractionated. So you can do a sort of a condensed version where it might be 2 to 3 weeks. If this is high risk disease, so if these women are young, if their tumors are high grade or positive margins, you can also consider doing a boost to the tumor bed or radiation to the regional nodes. Women with mastectomy, on the other hand, don't generally get radiation, but they can. So if they're very high risk, so if it was a very large tumor, if their lymph nodes are positive, if they got positive margins, you can get chest wall radiation and nodal irradiation. Women who are older than 70 with early stage disease, there's really probably no benefit of adding radiation to lumpectomy. So these women can sometimes avoid this treatment. Family docs are very familiar with bisphosphonates in the setting of osteoporosis. For breast cancer, their use is different. So IV bisphosphonates are given every 6 months for 2 to 3 years. They're given in intermediate to high risk cancers in postmenopausal women. And the reason they're given is that they've actually been shown to decrease breast cancer mortality and also decrease in-bone recurrence. And now we get to endocrine therapy. For many women, this is the mainstay of their treatment. And so I'd like to spend a little bit of time and talk about the different drugs that are involved in endocrine therapy, just so you understand a little bit about how they work and the side effects that you can expect from these. Because if these women are on these for 5 to 10 years, you're going to see them in your clinic and you're going to want to know what side effects you need to watch out for. So again, endocrine therapy only given in ER/PR positive disease. The different agents that are used are tamoxifen, aromatase inhibitors, which include letrozole, anastrozole, and exemestane, GnRH agonists, and fulvestrant. So this is my pretty picture I drew to try and show you how they all work. So essentially, estrogen here are the pink dots, and the purple cups are the estrogen receptors. So for endocrine therapy to work, you either want to stop the pink dots from going into the purple cups, or you want to just decrease the amount of estrogen or pink dots that's out there generally. So you can do this in a number of ways. With GnRH agonists, you can block the central signal going from the brain to the ovaries and block estrogen production. If you want to target the receptors, you can use tamoxifen, which selectively binds to it but doesn't activate the receptor in the same way as estrogen does, or fulvestrant, which degrades the receptor. Aromatase inhibitors work differently. They stop the conversion of peripheral testosterone to estrogen. And so they decrease the amount of estrogen circulating because of that. So tamoxifen can be used in both pre- and postmenopausal women. Again, big reductions in mortality here. Reduces 10-year mortality by about 31% and recurrence by about 40%. Side effects are venous thromboembolic disease and increased risk of endometrial cancer. So any woman that is on tamoxifen who presents to you with postmenopausal bleeding needs an endometrial biopsy. This also causes vaginal dryness and hot flashes. Aromatase inhibitors are for postmenopausal women only. They basically add another 10% benefit to those figures from tamoxifen. Side effects are very different. So hyperlipidemia, osteoporosis is a really significant side effect of these drugs. And they'll often cause really disabling arthralgias and myalgias. And this is really what limits a lot of women from taking these regularly. And so it's really worth checking in on compliance because we know that they can be difficult to take. You'll notice that I said some of these treatments can be used premenopausally, some postmenopausally. Why does it matter? So if you think back to that diagram, if you're premenopausal, so your ovaries are still functioning, if we block peripheral production of estrogen, your ovaries will just upregulate the production of estrogen. And so you actually end up with higher levels of estrogen than you would normally. So it's actually quite dangerous to use aromatase inhibitors in premenopausal women. So here are your options for endocrine therapy. If you're premenopausal, you could generally be on tamoxifen. If you wanted the additional benefit of an aromatase inhibitor, you can add ovarian suppression. So you can block those ovaries from functioning. And some people want tamoxifen plus the added benefit of ovarian suppression. If you're postmenopausal, you can use tamoxifen, you can use an aromatase inhibitor. And sometimes people go with what's called the switch strategy, where they do a few years of tamoxifen and then switch to an aromatase inhibitor, mostly because aromatase inhibitors can be tough to take. You should be on these drugs for at least 5 years. If you have high-risk disease, node-positive disease, the benefit looks like it goes up to 7 years. There's no survival benefit really beyond 7 years, but if you stay on them up to 10 years, they continue to prevent the development of new breast cancers. So that's all the arrows I have now, but the question is, what's coming up? And so there are some things that may be added into the treatment of breast cancer in the future that are just interesting to know about. Immunotherapy is the new kid on the block in oncology, and its role in breast cancer is being investigated. It may have a role in triple-negative breast cancer, but really it's not determined yet. CDK4 and 6 inhibitors. These are palbociclib, ribociclib, and abemaciclib. These are newish drugs that really act to stop or slow cell division. They're used primarily in the setting of metastatic breast cancer, where they're now first line for patients with endocrine responsive disease. And in the first line setting for metastatic disease, they have a survival advantage, or a disease-free survival up to 20 months. Now the trials are starting to try and put them earlier on, and so we'll wait to see what happens there. So after your patient's been through all of this treatment, they usually get sent back to you, the family doctor. And it can be quite intimidating to take over the care of these patients, to know that they've had all these different treatments and you're not sure what you should be following or what you need to be worried about. So this is partially what led to the creation of the breast cancer survivorship tool. This is something we created through the Cancer Care member interest group at the college. It's been peer reviewed, it's evidence-based. It basically summarizes everything you need to know about breast cancer survivorship care. It's available on the CFPC website, and you can also Google it and find the link. What I suggest is you fill it in, you print it out, you scan a copy to your patient's chart, you give a copy to your patient, because it really empowers patients to know what their survivorship care should be like and what they should be looking out for. So the breast cancer survivorship tool is set up in 4 stages. First stage is always to know your patient. So clearly, if they've had trastuzumab, if they've had chemo, if they've been on an AI, their care and what they're going to need and what they might run into in terms of side effects is much different than if they haven't. So you have to know really what their treatment was. The next thing you need to think about is how to make sure that that cancer is not coming back. You need to think about what are the long-term side effects that they're going to get from their treatments and how do you manage them. And the step that we tend to forget with breast cancer survivors is health promotion. So family docs are so busy trying to think about all the other things in their short appointment with their patient that they forget to do pap smears and fit testing and all the rest of the stuff that we're so good at usually. So I'm just going to show you a little bit of this. Well, I'll show you the whole breast cancer survivorship tool. So the second step looks at cancer surveillance. And so it goes through what symptoms might suggest cancer recurrence and how to work them up. And it goes through a very clear algorithm of what you need to do for these patients. So essentially, you should be seeing them every 6 months for a history to try and determine if they have any signs or symptoms of recurrence or side effects. And you need to do a physical exam. So that's a breast exam. You need to check nodes. You need to look and make sure they don't have hepatomegaly. These patients should have a mammogram yearly, and this should be a diagnostic mammogram, not a screening mammogram. Patients are encouraged to do a breast self-exam monthly. So this is very different than what we were talking about at the beginning with screening recommendations. You should screen your patients at their visits for depression, anxiety, because we know that the rates of these issues are much, much higher in breast cancer survivors than the general population. And if they have been taking an II or they are on an AI or GnRH agonist, you need to be monitoring their bone density fairly closely. So every 2 years, and you need to be monitoring their lipids. Step 3 goes through long-term side effects of treatment. So the tool shows you what possible side effects these might be, and it gives you suggestions on how to manage them, all of which are evidence-based. And finally, step 4 goes through health promotion. So making sure you have those discussions around healthy weight, physical activity, smoking cessation, limiting alcohol, good nutrition, because we know all of these things help reduce the risk of recurrence. So I hope that today, I mean, I've done a big walk through breast cancer, but I hope that you feel more comfortable with it as a whole, with the workup, with the diagnosis, with the treatment, how to look after these patients after. And I'm happy to take any questions that you may have.
All right, Anna, that was great. Thank you so much. And thanks for covering so much information and doing it in such a concise way that you were able to fit it all in. It was fantastic. Okay, so there have been a few questions that have come through. Some of these questions will be related to some of the things you said. So if you're repeating some answers, that's okay, because it's always good to repeat important information.
Sure.
So the first question is self-breast examination never recommended sort of in 2020?
Right. So Canadian Task Force guidelines say that it is not recommended. I think, you know, it's a personal decision, but if you're going strictly by the guidelines, they would say no.
Okay. And just to follow up sort of in the same theme, can you just review maybe your own approach from your practice for women who are under age 50, but they feel strongly or expressed their opinion in a strong way that they want breast cancer screening tests ordered. So how do you sort of approach that if they're, let's say, between 40 and 50, or even, reaching 40? Like, have you had those situations, and how do you handle them?
Sure. I mean, I think, quite honestly, this is a discussion we should be having with every woman between 40 and 50. You saw those graphs there. These women do get breast cancer and they do die from it. But I do think that clearly there are risks for screening. There's false positives, there's unnecessary biopsies. So you need to understand that patients appreciate the risks. But if a woman felt strongly about it, I would absolutely order her a mammogram. The thing about screening women in their 40s is you probably need to do yearly mammograms for women 40 to 50 because, given that mammogram isn't such a good test for these women because of the glandularity of their breasts, often you need to be doing it more frequently.
Okay. Here's a question about treatment. If a woman presents with a lump that's, I'm assuming it's a malignant lump, less than 5 centimeters, but is unable to receive radiation therapy, do they still need a mastectomy?
Right. So lumpectomy is only done if you can receive radiation. So sometimes women might not be able to get radiation because they're pregnant, because they have connective tissue disease, or things like ulcerative colitis, some autoimmune diseases where you might not want to consider radiation. And so in these settings, you probably would have to go ahead and do a mastectomy.
Okay. Before I get to the next question, I just, there was a shout out for you on one of the comments on Facebook. Great presentation, clear, concise. So always nice to receive positive feedback. So there you go.
Thanks.
Thank you to our members for taking the time to write comments as well as questions.
Appreciate it. Thanks.
Okay. The next question is, are genomic tests now routinely offered and insured? And then the sort of sub-question to that is this for node positive women only, or both node positive and node negative women?
So again, I'm really only familiar with Ontario. I don't want to comment sort of across the country, but certainly in Ontario it is funded now. And it is, I believe, any nodal status.
Okay.
I'm not sure about the nodal status. For sure, it's women who have negative nodes. I think it would depend a bit on the tumor characteristics, because if they were going to get chemotherapy regardless, then it's less helpful.
Okay. Okay. The next question has to do with investigations. So, is there a role for MRI or ultrasound screening in addition to mammography for women with dense breasts?
Right. So again, this is something where there's no real guidelines at the moment, but if you're following what radiology is suggesting, for women with extremely dense breasts or dense breasts, you want to be looking at doing, if you're going to be doing mammography, doing it yearly, much like that 40 to 50 cohort, so that you don't end up with those interval cancers. Ultrasound can be used as supplemental screening if they're intermediate risk. Again, I would go back to calculating the woman's breast cancer risk, right? So using that IBIS tool that's online, it's free, it's readily accessible, and it really gives you a sense of a woman's risk. If they're intermediate, you could add supplemental ultrasound, but again, it's not in any sort of organized screening program at the moment. If they're high risk, you'd want to think about referring to a high risk program, and they would be the ones probably ordering MRI.
Okay. And the sort of link or reference you just mentioned, we'll get that from you after the webinar, and we'll add it to the website that will have this webinar, the recording of this webinar, so other people who either watched it once or didn't have a chance can review it and then check out your results. Well. You
can also just Google IBIS, IBIS, breast risk calculator. It'll pop up.
Okay.
You're Googling it right now?
I wrote it. I just wrote it down. I'm taking some notes here as well for myself. Okay. the next question, to follow up the one we just talked about, let me just do this slowly. So if a woman under 50 has dense breasts, is there a role for additional imaging like ultrasound in follow-up to surveillance after she's received treatment for breast cancer? I can repeat that if that was too...
Okay, so this is asking, I guess, about follow-up treatment for, this is survivorship care, not just screening.
Right.
Yes, I think there would be a role. Again, I think if you looked at that woman and she'd had a personal history of breast cancer, then her risk might be high risk, and she may be followed by a high risk program if she's got really dense breasts or a significant family history. But I think you could consider ultrasound in that setting for sure.
Okay, perfect. The next question is, again, we're going to go back to screening now. I'm sorry to jump around.
Okay, that's okay.
So if you have a patient who has very dense breasts that you're screening, so I guess on mammogram, it's mentioned that they have very dense breasts. Do you then recommend ultrasound, like the next time around, or even at that point, would you recommend ultrasound as part of that screening, or is it just the frequency of mammograms that's important with regards to breast density?
So I think that's sort of similar to the question I answered before. So a woman with dense breasts, so that's category C or D, should probably be getting mammography yearly instead of every 2 or 3 years, just because there is that risk of interval cancers. And in terms of supplemental screening, if they're intermediate risk based on their lifetime breast cancer risk score, you could consider supplemental ultrasound. If they're high risk, you'd want to refer them to a high risk breast cancer program where they might have MRI available to them.
Okay, no, that's very clear. There's a question here about aromatase inhibitors. Do women taking aromatase inhibitors have higher testosterone levels, sort of as a consequence, and then do they get side effects related to that?
That's a really good question. I don't think they have appreciably higher, but I actually don't know the answer to that one. The side effects the profile of side effects I've seen from them don't include side effects from high testosterone, so I don't think it's a significant issue. Really, the side effects are the ones that I went through there: the osteoporosis, the hyperlipidemia, the arthralgias, the myalgias.
Okay. And I have another question of my own I'm just going to ask, because you definitely talked about self-breast exams. I'm just wondering, and I know there's probably not one right answer to this question, but for physicians that are doing periodic health exams, whether they're doing them focused or they're doing them with a certain frequency, clinical breast exams for women that are in the screening age, let's say over 50, is that still something that you incorporate in your practice with regards to the discussion on screening?
These are difficult questions, right? Because the task force tells us not to do these things. Personally, I leave it up to the women. I offer it to her. I think there's other factors. I think as physicians, we lose some of our physical exam abilities. If we never do a breast exam, then when we have an abnormal breast, we don't appreciate it necessarily. And I do think there are masses that are found on self-breast exam and clinical breast exam that wouldn't be found otherwise. So I know that I have a very biased view of this because I work in the oncology world. I see women with terrible breast cancers at all ages, 40s, 50s, 60s. And my bias is that we should be doing anything we can to stop these. I did go over some of the evidence that I feel, we know that if you're not just relying strictly on randomized controlled trials and you're looking at some of the other evidence, it might be different recommendations. But if you're following periodic health task force recommendations, they would say no. Personally, I give patients, I discuss it with them. I give them the option if they want it. It's not a simple question.
Yeah, I think the point you just made, though, is a really important one. And you've made it a couple times in your presentation, that there is a very high value of having these discussions with patients and going over the risks and benefits and making sure the patient is part of that conversation. And I think that that's a very reasonable approach, and something we should probably be doing with most modalities within our office practices. Okay, so we're running short on time, but just before I sort of do some housekeeping to finish up, is there one or two take-home messages you want to emphasize again, or that you wanted to tell the audience as we're sort of signing off of this talk?
I would say it sounds like a lot of people have questions on dense breast, so I would really refer you to that risk management tool or risk predictor tool, the IBIS tool. I would really recommend you have a look at the breast cancer survivorship tool, because it's really helpful in terms of how to manage these patients. And I think my other plug would be to really think about, make sure you have that discussion with women age 40 to 50. Because, women do die of breast cancer in their 40s. Okay.
Well, Anna, I can't thank you enough. This was a fantastic webinar. Lots to think about. We'll add some of those links to the things that were in your presentation for the audience that both watched today and that will be watching at a later date, so they can check that out. And really, thanks for all the time you put in, and for all the time you're putting in with the Cancer Care MIG at the CFPC.
You're welcome.
So just a couple housekeeping issues before everybody signs off. Again, to claim Mainpro Plus credits, please fill out the online survey. It'll be open until the end of day Friday this week. The survey link has been shared in the chat boxes for those viewing live. We do have some upcoming webinars I just want to mention quickly. The next English webinar is October the 6th, which is 1 week today. We actually have two public health speakers from both coasts, one from BC, one from Newfoundland and Nova Scotia, Dr. Monica Dutt and Dr. Meena Dawar, along with Dr. Jennifer Young, who's the family doc and a past president of the Ontario College of Family Physicians. They're going to talk about emerging issues associated with the second wave of COVID-19 pandemic that family physicians are currently facing this fall. And the discussion will include back to school health and safety issues, return to work requests for sick notes, and creative tips on running flu shot clinics when faced with COVID-19 logistical challenges. So please mark your calendar for that. We also have two upcoming French webinars on October the 27th, so later on in October. The talk that was given today, Demystifying Breast Cancer, will be repeated in French by Dr. Jen Chaput, who is Anna's partner in crime on the Cancer Care Member Interest Group. And so she'll be presenting in French, which is great. And then on November 16th, we have a talk in French on end-stage dementia with Dr. Marcel Arcon. So the final reminder is Family Medicine Forum. Family Medicine Forum will be taking place this year. It'll be virtually from November 4th to 7th, as listed on the screen right now. It welcomes family physicians, residents, and medical students from across the country. The event will offer 4 days of clinical sessions, virtual networking, online exhibits, and posters. We encourage all of you to register before September the 12th, which has already passed. So if you haven't registered already, you can still register. You've missed the early bird pricing, but that's okay. And please go to the website that's there, fmf.cfpc.ca. And I'll be there. We really hope that a bunch of you can join. Lots of great sessions. And again, thank you all for joining us today for the webinar, and we'll see you again soon.